From Ausmed Education, hello and welcome to episode 9 of the Care to Learn podcast series. I'm Wayne Woff, and each month I sit down with interesting and influential professionals working within healthcare and education. In this episode, we're sitting down with Geoff Ahern, a senior mental health clinician and educator. Geoff splits his professional time between responding to mental health emergencies with Victoria Police and educating health professionals and members of the community about mental health, substance use, and addiction. In today's episode, we'll discuss why all clinicians in mental health must learn to leave their unconscious biases at the door and start and finish with the individual client's story. Secondly, how workplaces can develop a positive culture of learning from the inside. And finally, why we, as health professionals, must learn to treat ourselves and each other with respect. So let's get into it. Well, welcome listeners to our Care to Learn podcast. We're very excited to have Geoff Ahern with us here today. Welcome to you, Geoff.
Thank you.
We'll kick off as we traditionally do. If you'd just like to give our listeners an idea of your professional background and journey for you as a healthcare professional.
Sure, I can do that. So nursing, obviously, started out doing my undergrad, Bachelor of Nursing, and worked in emergency and trauma for 4 or 5 years, I think, from memory, and then slipped across to mental health and have spent the rest of my career working in mostly crisis mental health intervention work.
And in terms of education, which is very much a part of your professional practice now, has that always been a passion for you?
Yeah, so it probably started out with learning, so educating myself, just passionately love researching and learning and trying as much as possible to be on the cutting edge of professional practice. And then about 10 years ago, a colleague had to pull out of a job. He was presenting, talking about psychopathology, and asked him if I could jump in for him, and gave me the slides and everything, and that I just kind of fell into educating as a result, and found out I quite enjoyed it.
So you caught the bug and education was going to be the way forward for you?
Definitely, because it's not just about educating. Every presentation you put together, you learn more yourself as well. So it just was another way of learning, almost forced learning, if you like, when you have to put a presentation together.
Yeah, and I would totally agree with that. I think there's a huge amount for educators learning in the preparation, learning from their audiences. Would you agree that there's a hell of a lot that any educator can receive back in a way from the audience that they speak to?
Yeah, particularly in the breaks when you get people coming up and wanting to talk one-on-one to you about their experiences, and being able to, I guess, there's a shared journey for all of us working in this field. So I can learn from their stories, and maybe they can learn a little bit from my story too.
Indeed. And in terms of mental health education, could you maybe speak to us a little bit about what you consider to be some of the emerging trends when it comes to modes of education, methods, strategies, maybe what you've seen that's remaining the same a little bit, but also what's changing in that space?
What I'm starting to see is the public system, which is where I work, people starting to take education and learning more seriously, because historically you take the ward setting and you're really busy and there's an in-service planned and it gets cancelled at the last minute because everybody's so flat out. But also just managers, taking it more serious and being willing to provide you with the conference leave you need to attend conferences and pay for things like travel and accommodation, some at least.
Yes, indeed. And when it comes to your general philosophy on teaching on mental health issues, what would you consider your key pillars or foundation principles that are your starting point for any education that you do?
I think, without a doubt, and we were talking about this earlier, the client, starting and finishing with the client. And when I did my undergrad nursing many years ago, my mental health lecturer actually made a comment to us. He said, if you're going to choose this field, choose not to become cynical and angry and burnt out, but choose to see the best in every client that you actually work with, and choose to see that it is absolutely possible that every person can recover. And so for someone to say that over 20 years ago, when we weren't really talking about hope for recovery, was pretty forward thinking, and it's never left me really. Yeah. And I think the person's journey, their story as well, in the work that I do, you spend first 20, 25 minutes just hearing their story, and that'll actually guide our practice in terms of how we can best support them.
I remember a phrase that was given to me early in my nursing career, and that was unconditional positive regard about clients, about their situation, whether they be a prisoner with mental health issues, whether they be a homeless person, whether they be a blue-collar worker or a white-collar worker, always to maintain that unconditional positive regard. So that really reinforces what you were saying there.
And I think it can be tough to do that working in mental health. And we see a lot of clients with significant mental health problems, but significant substance use problems as well. And so having unconditional positive regard for somebody with a substance use problem, when we get such negative messages in the media, I think can be very challenging. And if somebody's unwell and withdrawing from a substance, they're not always the nicest person to deal with. So that can make it pretty challenging to keep up something like unconditional positive regard for them.
And in terms of teaching professional students, whoever they be, just picking up your point about substance abuse and the fact that they can present in a manner which is incredibly challenging, what are some of your key messages to them as to how they can best cope with that?
Patience. Just be patient and spend a lot of time listening. It's amazing if you let somebody vent for a little while when they're really distressed, and they can tell that you're listening and taking the time to genuinely invest into active listening, they start to drop their guard and tell you more of their story, and they relax a little bit and become maybe a little less hostile if they're presented in a hostile manner. So it's really easy to be knee-jerk with a client like that and almost be hostile in our own responses. But I think just being patient and giving them some time is really important.
Yeah, it segues very well to a point that we've discussed at a few of these podcasts, and that's the balance in terms of the skill mix needed, and we're talking mental health today, between what might be characterised as soft skills, communication, listening, negotiation, mediation, and clinical knowledge, if you like. And in this area, and you've already touched on it, those soft skills are incredibly important. You would agree?
Absolutely, yeah. And the education, the clinical skills that you have actually underscore those soft skills, because I might be actively listening to you, but I'm actively thinking about where we're going to go with this in terms of how we're going to best help this person as well. And that's coming from a clinical perspective in terms of best options for them in terms of treatment.
And in terms of just moving a little to the left now, what do you think are the most significant impediments to staff embracing ongoing learning in your field of mental health?
I think my personal observation is there's still this kind of subtle resistance amongst some staff to education and the important role that it actually plays in your development as a nurse or a clinician, whatever role you're actually in. And so I see that as a barrier, because that'll hold people back. You hear people making negative comments about somebody might learn a new skill and it comes out in their documentation, and then somebody will make a negative comment about how they're showing off with their new skill, or that kind of that subtle pulling, the tall poppy syndrome still seems to be there in a few places I've worked in anyway.
Yeah, so that the environment to which they're taking their learning back to becomes quite critical in terms of the peer situation.
Yeah, absolutely.
And whether that's recognised and embraced, or whether that's seen of you're trying to be the smarty in the group in a way.
Yeah. Which is a terrible thing to see that happening.
Yeah. And do you think there are particular ways, and it would be more difficult in your situation if you're providing external education, but have you ever been in the situation where you've been able to be in those units and try and actively influence that through education or through consulting with those units, and how you can try and break that down?
Certainly have with education, but one thing that I've found to be really effective is just to get alongside the people that want to learn and almost kind of in a clandestine manner kind of make a commitment change the way we might view education in this particular unit, for example.
Yeah.
So you've got somebody that's got your back. And I've seen it work really well when people actually band together and say, we're going to make this a priority and change the culture within a unit. And you can do that very gently, and you can nudge people. You don't have to come in, all guns blazing and putting people offside. It can be done quite gently.
Yeah, and I think sometimes it's how you approach the other staff. In terms of a colleague of mine, again, taught me early in my career, sometimes you need to put it to people to choose not to embrace it. So the wording that you use, I learnt this terrific new skill, bit of knowledge, I thought I'd share it with you. What do you think of that? Do you think we could apply it? When people have to push back and say no, they're less likely to do it if you offer it in a very constructive way rather than try and impose it on them. So I think you're quite right. Sometimes it depends how you go about that in terms of negotiating what can be a bit of a minefield with other staff and their willingness to jump on the education bandwagon as well.
Definitely, yeah.
Along with that conversation potentially about the impediments to staff embracing ongoing learning is another interesting conversation that we've been having regularly in the Care to Learn podcast about barriers to translation of knowledge into practice. It's one thing for people to be well educated, to attend seminars, to do lots of readings. It's a significant challenge to see how that translates into practice. Your comments around that space and your learnings over the journey?
I think one of the reasons it fails to translate is because this, again, with nurses, we seem to be hard on ourselves and compare ourselves to other health professionals and often put ourselves down, see ourselves as a lesser profession rather than an independent profession. And I think that can impede you from applying your clinical knowledge for fear of what people might actually say, and things like being able to go back and look at the policies and the procedures on your ward and practice to the scope of your practice, like practice right to the edge of it, because you've got the skill and it is a part of the policy or procedures of the unit. But I think we can be our own worst enemies sometimes, because we do. There still seems to be this undercurrent of seeing ourselves as a lesser profession than other health professionals.
Yeah, no, I think that's very true. And just going back to your point about the work that you've done in the alcohol and drug abuse space and the education of clinicians in that area, what are some of your observations and some of your approaches that you're using in that educational space, particularly in teaching people about clients who are suffering from those situations?
I think getting people to understand, whether that be a nurse or a doctor or a social worker in any discipline, to understand that every person has a story and there's a reason they're using that particular substance. And there must be a pretty big darn upside with that substance use if they're prepared to use it despite the downside. So the person who's misusing alcohol, and we turn around and we tell them, kind of basically infantilize them, really treat them like a little kid and tell them that don't you realise this is causing problems to your liver? Well, of course they know that. Every grown adult in Australia knows that alcohol misuse damages your liver. So we can be quite patronising towards the person, but if somebody is using alcohol to the point where it's causing significant harm to their liver, there must be a big upside to that, and that upside is born out of a story, and often that story is mental health problems or trauma or loneliness or isolation or unemployment. There's a story behind every person that we actually work with, and I think we fail to get their story and really delve into it, and we can be quite patronising towards them.
Yeah.
And not intentionally. I don't think it's maliciously. I think people don't stop to realise that approach can actually add to the person's sense of shame and stigma around their substance use.
Yeah. And that concept of making judgment is huge in this space, isn't it? And particularly within that conversation about alcohol or drug abuse and how we're able to set our judgments aside. Becomes enormously important, I would imagine.
Yeah, so whenever I talk about substance misuse, I always start by talking about unconscious biases that we have that we're not aware of. So a good example is the average person in Australia won't give a homeless person who's begging for money. They'll give them food for fear that this unconscious bias that homeless people are going to buy alcohol and other drugs. We actually know that in excess of 50%, at least 50% of people, if you give them money, will buy things that they need. They're homeless people, they don't actually buy alcohol and other drugs. But we don't stop to think about these unconscious biases and how they sit there and where they've come from and why we might think that way.
So your educational approach to that area is that you try and unpack that with your learners? Have a conversation about them, get them to look at their own biases, their own situation, how they would think about certain things. You really get them to question themselves.
Yeah, I love starting as a starting point, getting us to stop and think about our views first before we actually move forward. Because there are so many myths and urban legends out there about things like substance use. But even getting back to mental health, only last night I was watching something on Netflix, some series, I can't remember the name of it, and a professional gentleman was giving advice in court, and he had an undergraduate degree, a master's degree and 2 PhDs, but then they found out later in the court case that he had schizophrenia. So the court case was dismissed because his evidence wasn't considered to be credible. I mean, that kind of message that we keep getting given around things like mental health and alcohol and other drug use, it's so pervasive, and we don't even stop to think about that somebody can be very high functioning and just as intelligent as any other person and be living with schizophrenia at the same time.
Yeah. And if staff, health professional, nurses aren't acutely aware of some of those biases, baggage, whatever term you want to give it, it can be a real impediment to giving the sort of quality of care and service that the client is in need of.
Absolutely. And so I tend to start with the unconscious biases and then finish with a slide that's a comic of people standing at an airport waiting to pick up their luggage, but the big sign above it says emotional baggage. And I love starting with that, finishing with that point before we move on to the clinical stuff and say make sure you leave your own emotional baggage at the door so it doesn't impact your practice when you're caring for somebody, because it's too easy. It's easy to do. I'm not being critical, but it's very easy to let our own personal emotional baggage as well impact practice.
And potentially your clinical decision making can be hugely impaired.
Absolutely.
By those things.
Yeah.
Okay, last couple of points for discussion today, Geoff. The first one of those is learning from our professional missteps or mistakes. From an educational point of view, how important do you see this?
I think the answer is actually in the question, that we actually step back and learn from it. Ask ourselves what can we learn from this particular misstep or mistake, if you like, rather than being so critical and harsh on ourselves and giving ourselves a hard time. Because I think most of us tend to be the biggest bully in our own lives. We tend to put ourselves down and give ourselves a hard time. And it's very easy to do that when you make a mistake. And we all make mistakes. I still make mistakes after all this time working in this field. But stepping back and saying, what can I learn from this? Rather than just beating yourself up and putting yourself down.
Absolutely. And the final thing we wanted to look at was education and support of clients and families. Is that something that is significantly on your radar when you're talking to the groups that you do about the need for them to be very good in this space, their ability to educate clients, educate people who are suffering from mental health issues, to speak to families, to bring them into the conversation? What would you have to say about those areas, I suppose?
Oh, absolutely. I think a part of our job is actually to educate, depending on how critically unwell the person is. But I was listening to a podcast with a cardiologist by the name of Dr. Geoff Ahern from the States only a couple of weeks ago, and he was saying the average cardiologist won't advise their client to change their diet because they think their client's not going to change their diet. And that's a big assumption to make. And so we've now made a very strong link between mental health and diet and nutrition, but we still don't advise our clients of this. We don't talk about things like diet and exercise. We make the assumption on their behalf that they wouldn't do anything about it anyway. And I think that when you think about it, is quite patronising to presume that the person won't change their life. So being able to take that information and use it as education, what we've learnt, whether they use it or not is their choice then, but actually giving them something practical that they can do. And I think often we forget that, and we do make this assumption that they won't change their their life or their behaviour.
And can you also just touch on, for a moment, support of family members, partners in the mental health conversation and the management, the delivery of care and service to these people, the significant role and the way we bring in those people to the conversation?
Yeah, because I've only moved to Melbourne 5 years ago. I'm not overly familiar with the history of their Mental Health Act, but I was in New South Wales when they changed the Mental Health Act in maybe 2007, I think, or later. But anyway, we were now legally obligated to involve families in the care of our clients, even if the person said no, they didn't want the family involved. We were legally obligated, and I think that is incredibly important. So the last 5 years that I've been working on the road with Victorian Police responding to mental health emergencies, you get to actually do that because you're going into a person's home. You get to actually see how disempowered the family often feels and how confused they are and how overwhelmed they are by the situation. Because for us, our unit that we're working on, whatever setting you're in, is very familiar to you. But very, very unfamiliar and scary to them. So I think it's critically important. And seeing it not just a legal obligation, but it's an important part of the person's care, is involving the family and easing their burden and their distress as well, if you like.
And my final question in this area is about how well we're educating health professionals, nurses, for example, in this space about the education of families. So taking one step back, are we giving enough good information and support to the staff involved in these situations about how to approach this, how to do it, to set up a good framework for them?
Certainly the area health service I work with, we actually have like a family's representative, and part of his role is continually reminding all the staff that we need to get family involved, and he'll send information out to all the staff about support programs for families. So certainly within my area that I'm working, we're seeing that happen a lot more. So I can't speak to other areas, but I would imagine it is starting to happen, partly because we're now legally obligated, like we have to. But just reminding people, don't discharge somebody from an ED without telling a family member, for example, when they just turn up on their doorstep at 3 o'clock in the morning. That would be incredibly distressing, I would imagine, for a family member to find out that we've not even contacted them to talk about this.
So as a general observation, we're doing it better now, you feel?
Certainly better than we ever have. I think we've still got a long way to go. And part of that is documentation too, actually. And we've seen some coronial inquiries here in Victoria recently where the coroner pointed out there wasn't enough evidence that we had made attempts, really good attempts, to contact family and get family involved. Even though it might have happened, the good old saying when you do your undergrad training, as far as the coroner's concerned, if it's not written down, it didn't happen.
Yes. We could spend a whole extra podcast, I'm sure, Geoff, talking about the fraught nature, the challenges of documentation within any clinical area, but particularly within that mental health space, and the need for huge clarity, objectivity, contemporaneous documentation, etc., etc. But that's probably a topic for another day. We will conclude our podcast today with Geoff, ladies and gentlemen, with our traditional final 3 questions. The first one of those: what's one thing you've learnt, Geoff, in the past month that has genuinely stuck with you?
I was thinking about that question. It actually has nothing to do with the clinical work that I did do, but I spoke to a group of parents about 2 weeks ago. Here in Melbourne, we ran a local council ran an evening on anxiety and young people. And I could see so many of these parents were so anxious about their anxious teenagers. And I think in talking to them, because there was lots of one-on-one after the presentation, I think we just need to relax a little bit. Particularly if you're new to mental health, just take a big deep breath and relax, and you'll probably find that everything will be okay in the end for the vast majority of the people that we care for.
I think terrific advice, and certainly my own personal anecdote in seeing 4 of my children through year 12 was just how much anxiety was generated by parents when I got together with other parents speaking about it, and how that can reflect back to the children. And I think that principle of taking a big deep breath is hugely valuable, and certainly in that anecdote it was. The second of our final questions, what's your favourite personal learning tip?
It's very simple. Listen. There's some really, really interesting research out of the States looking at nurses and doctors and their listening skills, and it's quite appalling, actually. We don't listen very well to our clients, and we need to be doing more of that because it directs our practice in terms of getting good outcomes by listening to their story.
Fantastic. And our final one, what's the best piece of advice you've ever received about continuous learning?
It was actually from one of my granddads. I remember him saying to me when I was still in high school, he said, the day you stop learning is the day you die, Geoff. Nothing to do with my career at all, but I've never, ever forgotten that.
Fantastic advice from Grandad. On that note, and a very good note, we thank Geoff for his time. A terrific discussion today, some terrific insights in this edition of the Care to Learn podcast. Thank you, Geoff.
My pleasure.